Hi, and welcome to this discussion about community and population health. My name is Tracy Morton. I'm the Director of Population Health at the National Rural Health Resource Center, and I'm the Program Director for the Technical Assistance and Services Center, or TASC. So the community and population health area within the FLEX program is an optional area, but it really intertwines with all of the work that we do in the FLEX program, including in the required areas of quality improvement and operational and financial improvement. I'd like to ground our discussion in a few definitions. And first, that is, what is health? And health can mean a lot of things to a lot of different people. But one definition that I really enjoy is that health is a state of complete physical, mental, and social well-being, and is not merely the absence of disease or infirmity. This definition is from the World Health Organization. What I think is really unique about this definition was that it came into being in 1946. And I feel like it's something in our organization that we are pushing on often, and what we're trying to do to reach the mission of our organization to support the state flex programs. But as a country, this is a definition that we're still striving for in the healthcare that we deliver day in and day out. It's also important to describe what is population health, because this is a definition, or excuse me, a word that can have many definitions as well. This is one that our organization gravitates to, and it's from the American Hospital Association. And it describes population health as a strategic platform that improves the health outcomes of a defined group of people, and it concentrates on three different stages: the distribution of specific health status and outcomes within a population, the factors that cause those present outcomes in distribution, and interventions that can be used to modify or improve those health outcomes. So an example might be that we're working with a group of type 2 diabetics that are between the ages of 25 and 45 years old, and that they're insured by Medicaid, and that they show up for maybe 50% or less of their first scheduled appointments to check in on their diabetes state. So that's a concern, right? We want people to show up for their appointments in our facilities to help modify their outcomes and help them with longevity and well-being. Because they're on Medicaid, we know exactly how our facility is going to get paid or reimbursed from them if we're pretending like we're in a critical access hospital. And we also know that they're not making those first scheduled appointments. So maybe there's some factors that are playing into that, and that could be helped with that. So that's our distribution of disease. We have a group of diabetics that are in a certain age group, 25 to 45 years old. We know how they're insured, and we know that they have some issues with coming to their first appointments. So then we want to dig deeper in population health into the factors that may cause those outcomes to be present. So we could look at other comorbidities that those persons or those people might have, maybe some other lifestyle choices, transportation availability or lack thereof that could be impacting their ability to attend to their appointments. Income could be a driving factor, access to healthy foods, access to or desire for physical activity could be helping them with modifying their current disease state. And maybe even reading level. Can they understand the information, the health information that's shared with them? And then the final area, or the final phase or stage within population health, and what are the interventions that we could do at our facility for a critical access hospital to support this population group? So maybe we can schedule during different hours, certainly after hours. If they're 25 to 45, they're in that working age group. So maybe those hours that we have 9 to 5 aren't working well for them to come out of their jobs. Maybe we could offer some lifestyle coaching in a way that's relevant to them. Maybe they need help with childcare to support them actually coming to appointments. Maybe we could address health literacy. We could find opportunities to provide physical fitness where they live, in the area of town, maybe where they reside or something like that, instead of relying on them to come to us at the facility. Or maybe we can give access to fresh groceries or some coupons for good produce that's local in the area or at the farmer's market. So that's just an example of how we can look at population health as this concept or strategic platform that has many different phases within it. Population health also is important as it can be used interchangeably in two different ways. One is a targeted population that's improving the health of and maybe reducing costs of a specific group of patients that are often grouped by insurance type or focused on a chronic disease state. So what I was just describing before with diabetes, that's an example of targeted population health. Total community health is looking at the health outcomes of an entire group of individuals, often that are grouped geographically, and maybe looking at some disparities or distribution of health conditions within that group. An example of total community health might be the market share area of a critical access hospital or rural health clinic. So those different ways of framing population health, either as targeted or total community health, can be used in different varieties within the concept of population health. And it's really important to clarify that when you're in a conversation with somebody, because they really intertwine very tightly with resources. In our healthcare system in the country, we're moving from a model that's based on volume into one that's based on value. And this value equation originally was described as looking at the patient value that was divided by the quality of the patient plus the patient experience divided by cost, and that's what equated to value. Over time, that definition has expanded, and now what we're really looking to do is have a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And this is a definition from the Centers for Medicare and Medicaid Services in their Innovation Center, which is driving a lot of innovation and change in the country within the healthcare marketplace. So rural, as you may be aware, is generally described, and accurately so, as older, sicker, and poorer than urban counterparts. And there are 5 leading causes of death in rural America, which is where 15% of Americans live. Rural Americans have greater risk of death from heart disease, cancer, unintentional injury, chronic lower respiratory diseases, which includes things like asthma, or like COPD and emphysema, and also stroke. One of the important factors, and if you remember back to that value equation, cost is on the bottom. And that is certainly a driver of healthcare in general in our country. What does it cost? Am I, as a patient, going to choose to go to the hospital? Is a hospital going to offer me certain types of services? Is the insurance going to reimburse that? All, unfortunately, at times driven by cost. This graph is showing some data that's from a few years ago, but it still paints the picture. And I know that none of this has changed drastically, though no more recent information is available at this time. But in 2018, this is looking at the total expenditures in millions of dollars by conditions in the United States. So the top cost expenditure in all of the US was osteoarthritis and other non-traumatic joint disorders, followed by mental disorders, other care and screening, diabetes, cancer, heart disease, etc. When we lay on top of that, those 5 leading causes of death in rural America, here denoted by the orange triangles, we can see that cancer, heart disease, and stroke, trauma-related disorders, or those unintentional injuries, and then those lower respiratory disorders are among the top 10 total expenditures of costs of healthcare in rural America. And that's why population health is even more important. But population health in taking care of the health of an individual does not happen only in the clinical care setting. So what this diagram shows is that there's many influencers that lead to the health outcomes. So at the top of the screen, there's green health outcomes, and next to that is 50% of the attributes that lead to that improve or impact the length of life, and the other 50% lead to an impact in quality of life. Below that, the health outcomes are driven by health factors, and those are the areas there in blue on the right. And below that, policies and programs are really what shape and mold and create the parameters that we have our health factors within. But if we look at those health factors on the right, we can see that 30% of the health outcomes are led by health factors related to our health behaviors, things like tobacco and alcohol use. 40% are driven by social and economic factors. And that includes education, employment, income, all those socioeconomic status types of things, as well as community safety. And then the bottom 10% is by the physical environment, or the environment that we live within. And as you can see, 20% of the health outcomes are driven by health factors related to clinical care, access to care, and quality of care. So as we tie this information back together, in our country, we're spending billions of dollars on care, on insurance, on trainings, on providers, all to influence just 20% of those overall health outcomes. So I'm not discounting the tremendous work that occurs day in and day out within our rural facilities and our urban facilities as well. It's all very important. We're saving lives, we're making better quality of life for individuals and helping them achieve their version of wellness. However, there are many other factors that come into play that we can't control within the walls of our hospitals and clinics. So we need, as a rural environment, to be linking into other community collaborations, organizations, practicing community care coordination to really make the best situation that supports our patients, our loved ones, our neighbors, and our families and friends to have the best health status possible for them. You may have heard the term of social determinants of health. Social determinants of health are the conditions and circumstances in which people are born, grow, live, work, age, play. And they're the circumstances that are shaped by a set of forces that are beyond the control of an individual. And these include things like economics, the distribution of money, power, policies, and politics. And these occur at the global level, the national level, the state, and the local level. These influence all of us, but they certainly can impact really those health factors and our ability to achieve health that really sometimes is outside of our own control. So when we're thinking about health outcomes, not only do we need to think about what we can do within our clinical setting as well as outside, how social determinants of health play in with those outside settings and the settings within our facilities, but we also need to think about health equity. And this really requires moving some obstacles that are in the way and being willing to move those obstacles that are in the way for achieving not equal, but equitable health for everyone. And what equitable health looks at is the meaning that everyone has a fair and just opportunity to be as healthy as possible. It means reducing and eliminating those health disparities and the determinants that adversely impact the outcomes and can marginalize certain groups of populations. So as you can see at the screen here, the top row with the bicycles is demonstrating equality. Everyone gets a bike. But on the bottom row, everyone certainly gets a bike too, but in an equitable approach, they're given a bicycle that fits their needs, their modalities of life. So I encourage you within your flex programs to not just be thinking about clinical care, but also be thinking about those social determinants of health, the policies, the systems and environments that we're within, the collaborations that can be, should be, and ought to be developed in our rural communities. And if we're creating an equitable approach, and if those that are in marginalized groups or groups that we are focusing our efforts on are not at the table in those conversations when we're designing those efforts, they need to be brought there. Otherwise, we might be creating some unintended consequences for them that may be harmful, even though we had well intentions to begin with. As I've alluded to already, population health has many partners, and you can see those displayed on the screen. I think the COVID-19 pandemic brought to light really how we as communities, as states, and as a country could come together and collaborate across our different walls and borders within our organizations to meet the health and emergent pressing needs that our communities had. So I encourage you too, within your flex program, to think about, of course, our flex work targets work to hospitals, rural health clinics, and emergency medical services. But what are the other partners and providers that we need to bring to the table to support needs? A great example of this is there's a facility in Vermont called Grace Cottage Family Health and Hospice, and they collaborate with an organization to run a volunteer driver program that helps patients attend their medical appointments. It also helps to build community. And it's this group that they work with, it's called Green Mountain RSVP, is a nonprofit volunteer-based organization of 55 years and older drivers who are there just to respond to needs and requests to drive people to and from their appointments, to get access to their wellness services. And they station this at the hospital, they're ready, available, and on call. They have a wide service area that they can cover and a wide variety of hours that they can cover and are responsive to not only scheduling, which we've heard sometimes can be a concern in communities, rural communities with transportation services, but will meet people where they're at with what they need as well. This program has been so successful that they've actually expanded fulfilling their request to transport people to the farmers market to access quality health foods to support their overall wellness approach. So why is population health important as we're thinking about our transition to value in the country that we hear more about here during this flex workshop? We need to move out of an unsustainable healthcare system. And though we are honestly moving through one that's focusing on value, but it's really developing unevenly. It's developing unevenly in both rural and urban areas, and then comparatively in those two geographies as well. We need to drive down our per capita costs. You saw the cost of some of those high conditions, and that we can do through shared savings and better cost controlling. We need to improve the experience and outcomes of care. I think that's what we as individuals and consumers of healthcare want. That's what our providers actually want to deliver. They want us to feel good. They want us to be happy and healthy. And they, as well as patients, are focused on quality and satisfaction. And we can use the electronic health record and other reporting tools as mechanisms to support that. And as Americans, I think we want to create healthier communities that are striving towards equity and have a relevance to a provider where they can rethink what care management looks like, and that rural providers can be that provider of choice. A little bit about what a community health needs assessment is, because I'm going to talk about that in a second here when I review the flex program areas. The community health needs assessment, or CHNA, was a created requirement by the Internal Revenue Service for nonprofit or charitable hospitals in 2009. Though the concept of community health needs assessments existed much before that. It's a method to define a community that a facility, rural or urban, but nonprofit, is serving, and what are those needs that the community, is desiring to support health in their area. And whether or not the facility itself can address all those health needs is actually probably quite unlikely, but that's again where collaboration comes in. There are methods that need to be utilized to complete the community health needs assessment to satisfy the Internal Revenue Service requirements. And hospitals need to complete these CHNAs every 3 years based on their own taxable year. So within your state, they can be on alternating different years among the facilities in your state. It's pretty straightforward in the steps, and there's lots of methods that can be utilized to complete those steps. And if you are interested in any further clarification or questions on that, please do let us know, as we can certainly help with clarifying those things. Within the Flex Cooperative Agreement, there is Program Area 3, which is about supporting population health, where we're looking to build capacity of community or critical access hospitals to achieve measurable improvements in health outcomes of their communities. There are 3 activities to select from within Program Area 3, and those include supporting CHs identifying community and resource needs. 3.2, which is assisting CHs to build strategies to prioritize and address unmet needs of the community. And 3.3, which is assisting CHs to engage with community stakeholders and population health experts in addressing specific health needs. So to talk a little further about those, again, 3.1 is about identifying needs, and some examples of what you can do in a Flex program to meet activity 3.1 to identify those community resource needs are planning and assessments, those community health needs assessments, aiding in local, regional, or state coalition building, or sharing information to prepare CHs for these projects. Now, a state Flex program cannot offer a CHNA as a service to the state Flex, to their critical access hospitals. They can support with the training. If you have staff within your state Flex program that can execute the CHNA service in kind for your facilities, you can do that. The critical access hospitals cannot use state Flex program funds, though, to complete their CHNA, as it is a federal requirement or an IRS requirement that those nonprofit facilities need to complete that every 3 years. Then we'd be using federal dollars to meet a federal requirement, so you can't do that. However, like I said, you can offer the training support to your critical access hospitals about how they can meet a CHNA. You can suggest to them other partners or providers that might be able to guide them through that service, or a consulting firm. And if you have the capacity and the staffing to complete the CHs on behalf in kind for your critical access hospitals, you can certainly do that. And an important aspect for Flex programs to consider in activity 3.1 is that you track on those CHNA completions, that you offer technical assistance and Q&A to your facilities to complete that, and you review what the health priorities are that are identified to understand the lay of the land, if you will, about what it is are the health needs within the communities that are supported by your critical access hospitals. There's a population health toolkit that we've designed here at the center through the TASK program that can help rural hospitals or other providers really understand where they're at in their journey into population health. There's an online readiness assessment, and it connects them to tools and resources based on their readiness to adopt population health management. And then there are great population health analytics resources on there where you can access specific scenarios to look at answering questions about is mental health at the county level and the data that supports that related to emergency department utilization in our counties. So there are about 15 different data scenarios pulling from federally existing publicly existing, data sources to cross out that information into a more complicated way that a layperson like you and I can utilize to see what some of the health needs might be related to stroke, diabetes, mental health, socioeconomic status, transportation, emergency department utilization, etc. So I encourage you to check that out. And again, let us know if you have questions. Activity 3.2 is where we kind of move more into action. So we've gathered our assessments and have an understanding of the needs within activity 3.1. And in 3.2, we can assist the critical access hospitals to build strategies to prioritize and address those needs. So things that you can do in your FLEX program here are taking those findings from the assessments and supporting your CHS with action planning, creating cohorts regarding maybe a group of hospitals have all identified mental health as a top need. So creating a whole cohort to support them. You can engage patients, partners, and communities into population health activities in this area, develop community activities, and facilitate collaborations. And then in 3.3, we're also moving into action. And in this area, you're assisting critical access hospitals to engage with community stakeholders and public health experts in addressing specific needs. So in this area, activities could include implementing specific programs to address needs or social determinants of health, maybe through networks or cohorts again, and really focusing on sustainable programs that can move beyond support within the FLEX program into their own sustainability or other funding from elsewhere to keep them as a community-driven initiative. So I'd like to kind of end with a great quote that I saw shared within the FLEX monitoring team report last year about how critical access hospitals are addressing the social needs of rural populations. And in that, it shared that critical access hospitals in the work through the FLEX monitoring team identified the three most important components to establish a critical access hospital-based social needs initiative: a support of hospital leadership, ample funding, and dedicated staff to engage the community. These are all things that can be supported through the FLEX program. There's a lot of leadership support efforts that you can do within your FLEX program to support those CEOs, the board members, physician leaders, and other staff influencers to understand population health, make policy changes within their organization, and create programs. And you can help them understand the why, the value in this, and support strategic and action planning. Regarding funding, there are in-kind, there's dedicated staff time, there's large donations that could be utilized to support this. There's grants out there, there's federally funds that could strategically be used. And how FLEX program can do that is you can support the seed funding for initiatives, like using the cohort approaches in 3.2 or 3.3. And you can drive for demonstrated outcomes. And you can encourage sustainability so that the programs, once they have these outcomes to share in a brief description, can then access other funding. And you can support them with grant writing or pointing them to grant writing resources and training. Or you can connect them with other groups of like-minded individuals to share resources and share opportunities. And then to support that dedicated staff, that's really about engaging and maintaining relationships and creating as a part of a job role that we're doing population health and that it's not an additive to an FTE. How FLEX can help with that is through education, again, strategic planning work, helping to understand the return on investment for community initiatives and outcomes. And what is the investment then? If we dedicate staff time in our rural facilities to this, how does that come back in? And supporting staff with training on topics, developing relationships, information about diversity, equity, inclusion, and health equity, sustainability, and projects. So that's a lot to cover here in a short amount of time about population health. Again, I'm really happy to answer any questions you might have. We'll get into this deeper as you get acquainted with your role within the FLEX program. But do know that we're a resource to you and we're happy to have you here.